I am super excited to be here today to chat with Dr. Nicky Keay, who's a leading endocrinologist specializing or having a special interest in bone health and energy deficiency, or REDS. So, Nicky, welcome. Super happy to sort of dive into a lot of these sort of topical conversations. So, can you just tell the viewers a little bit about yourself?
Well, first of all, thanks for inviting me here. And so I'm a medical doctor, as you said, with a special interest in hormones, particularly related to people who are doing activity exercise, because as we're probably going to discuss, hormones, in my opinion, are key to many aspects of health, including bone health, but many other things, by the way. And also from the exercise point of view, I'm very interested from a personal level. I've always been keen on doing sports, swimming, tennis. Dancing is my main thing. And it always intrigued me with that connection between doing exercise, and we all know the benefits of exercise, but I wanted to understand exactly how those benefits come about, i.e. we're going to talk about the hormones, and also the pitfalls, what can go wrong. That, you know, if you don't quite get the right balance between your exercise and your nutrition. And you mentioned REDS, relative energy deficiency in sport, but I just want to highlight, don't think it's just elite sports people. It's not. It could be anybody that hasn't got the balance right in whatever way that might be.
Cool.
So, that's all about me. And, I'm delighted to dive in.
Cool, perfect. So we're going to start with bone health, if that's okay. It's almost been considered the silent sort of killer or silent epidemic at the moment. And there's been quite a lot more awareness about this, and rightly so, because we've got almost 50% of females over the age of 50 being diagnosed or being osteoporotic, perhaps not even being diagnosed, and almost 30% of men over. So it's not just a female condition. So could you start by telling us a little bit about what is osteoporosis?
Well, maybe, Simon, we go back even a step further. Let's talk about bone. Because bone, if you say the word bone, most people think, oh, that's very boring. It's just a static tissue. But actually, the bone is really dynamic. The whole skeleton might get turned over every 10 years or so. And so there's a continual...
So it takes 10 years
roughly,
to turn over.
Roughly, the whole skeleton will be turned over. So it's like a recycling process. So it will be broken down and then reconstituted, if you will, right? And usually there's an even balance between it breaking down and building up. Why does it do that, you might wonder? Because it's a metabolically active tissue. It's got some good calcium stores in there. But also it's actually so that the skeleton can adapt. So if you start running, then actually you need to strengthen your hips, for example. And so this is why this turnover process is useful. However, and it should be, as I say, even. The sort of the ones that are breaking it down, the ones that are building it up. That should be the balance. But as we get older, then the balance tips in favour of it breaking down. Right? And by the way, this bone turnover is regulated, of course, by hormones. So estradiol is the most active form of estrogen, and we all think, oh, this is a female hormone. And of course, women produce a lot of it during their menstruating years. But men, by the way, have to turn some of their hormone, their testosterone, into estrogen. So estrogen determines the balance of the building up and breaking down. And so this is why especially for women reaching menopause, when the ovaries retire and the levels of estrogen drop, this is why now we haven't got the driver of the formation side of the equation, if you will. And so this is why the bones can become weaker. And similarly for men, the testosterone goes down a little bit, but not so much, which is why there's not such a high incidence of osteoporosis, weak bones. So that's what happens when the balance of the breaking down and building up. And if it gets to such an extent that it's being broken down, then this is what that word osteoporosis means. So it means at a certain level of degradation, I suppose we would say, of the bones, that's when the bone is osteoporotic. And if you look at it sort of at the microscopic level, you'll see the bone normally this very strong honeycomb structure, but osteoporotic bone has got big gaps between it, like Edam cheese, as I say. And so if you picture, that's what osteoporosis is. And now we can see why you're going to be more at risk of getting a fracture, Because if you put any force through that weakened bone, then it's more likely to fracture. And the reason it's called the silent killer is because it's not a sudden thing. It's not like if someone has a heart attack, it's like quite dramatic and it could kill them, frankly. Whereas osteoporosis, because it's this slower process of the mismatch between the degradation and formation of the bone, then it gradually happens. And as you say, you might not even realize until you slip and you fall and then you break it and then you realize. So that's why it's silent, because you don't realize it really. And actually, ultimately, it's a killer, but not a sudden thing. Because with this, the weakened bone, the posture, the slump posture. I'm thinking of my mother. I'm conjuring up this picture of my mother now. The dowager's hump.
Relate to that.
Yeah, exactly. If you think about your mother or your grandparents, especially the woman, they do shrink. They lose height because the bone's squashed down because they're weaker. They get a posture, slump forward, can't breathe so well, and they're more likely to fall, trip over and break their hip, which hasn't got good data if you go in for with a broken hip, elderly.
That data, we know that, almost 60 to 70% of people over the age of 60 who fracture their hip don't survive beyond a year.
Yeah, or if they do survive, they can't get their independence back.
Yeah.
So now they're limited. So that's why it is a silent killer, and it potentially is not, it's not great, but the good news is if we know the principles about what's going on, now we can hopefully do something about that to prevent that happening.
So just to go back to your sort of bone health view and that sort of bone remodeling, exercising is critical to your bone health, and exercising through the younger years, in particular sort of teenage years, is absolutely critical to bone health because you achieve your peak bone mass around sort of 30-ish.
Or maybe even earlier in women, we think. But it's variable. So yes, what can you do? Now we said this is osteoporosis. You don't want to develop this. What are you going to do? So actually, we have to dial the clock back and say, when are the times when you can get the most gains, I suppose you could say, in your bone health. And you're absolutely right. It's those teenage years, puberty, when the sex steroid hormones are coming online. In the girl, in the woman, her periods are starting. So obviously now she's producing estrogen. But as we said, the men are now, their testosterone levels are going up, and so some of that is converted to estrogen. So estrogen becomes available, right? And the bones love that. They lap that up. And so you're going to reach your peak bone mass. Yes, 30, but I would say there are some evidence now it might even be sooner, or at the very least we know the maximum increase is during the late teens, early 20s, put it that way. So maybe you can get a little bit later on, but so being mindful of that, and then continuing to encourage youngsters, teenagers and especially, to continue their exercise, because loading the bone to give that stimulus, osteogenic stimulus as we call it, and also bearing in mind that the hormones are key.
Touching on that, osteogenesis is
building the formation. So it's the formation side of the equation. So, and in order to stimulate that, remember I said why does the bone turn over? Because if you start running, then it will respond and lay down more bone, you see. So if you're doing this, encouraging bone to form, especially during that critical time when you can really get some good gains. So exercise is key, but it's got to be matched, obviously, with sufficient nutrition and rest and all this sort of thing. So that's a really important time during those teenage years. And then once you're past that, and hopefully you've now attained your peak bone mass, then the next challenge is to maintain that during those adult years. And then, as we say later on, when the hormones are going to go down a little bit as we get older, 40s, 50s and further on, then the same principle. So it's the same principles throughout our life of the exercise and sufficient nutrition and sleep.
Types of exercise are better than others. As in, in the teenage years, or lateral movement, pivoting, football, hockey, basketball, all those sort of sports are fantastic, as well as some sort of impact running, but too much can also present other issues, which we might touch on a little bit later.
Yes, that's a really important point. So when we think loading the skeleton, I think everyone will think immediately running, right? But I mean, it's okay running, but it's all in one plane, one direction, like you said. So really you're looking for something where there's a change in direction. So it's depending on your age. So you mentioned rugby, football, tennis, by the way, you know, things like this that change dancing, of course, that's the ideal. But, you know, as a 50 or 60-year-old, probably you shouldn't be playing rugby or you don't want to, but there are other ways around that. So it's basically it's
Touch
changing
rugby,
direction.
walking rugby.
Yeah, exactly. Or tennis you can still keep doing, or dancing, of course. So it's changing direction is the best way of stimulating the bone. And also we know that strength training is very helpful because changing direction is definitely very good for the legs and a certain extent for your spine. But actually doing strength training, weight training or resistance bands or something that's going to actually load the skeleton from the top down almost, that's also going to be really helpful for the spine especially. So ideally it's a combination of all these things. And actually that is a recommendation for exercise throughout all the years to do strength training.
Yep, definitely. And we'll touch on that a little bit. But just to point out that swimming and cycling are not great for bone loading. And, you know, we see a lot of professional cyclists who've, certainly in the past, I think they're better managed now, have been osteoporotic. And swimming doesn't put the sort of load in the system for bone development.
That's true, but you know, that's not to say if you like swimming and you like cycling, you shouldn't just pack it in. What you should do is complement that with some specific strength training. And in fact, we did a study, Simon, a couple of years ago, specifically on male cyclists, and it showed exactly what you're saying, that they're not loading their skeleton either, you know, from the feet upwards, nor are they doing strength training, because I know I live in a family of cyclists that are either on their bike or on the sofa. Nothing in between. No, nothing in between. Exactly. So, so these sports are very good, obviously, for cardiovascular system fitness and enjoyment, but always should be supplemented with some sort of strength training. But the problem is, I know that some people, especially in the older years, will say they've got joint problems and they don't, and actually they find swimming really good. So, you know, swimming does something. Because
it builds endurance,
and also capacity. you know, the muscles are pulling on the bone. So there's a little bit.
Some traction.
So there's a little bit. So it's not totally useless, but even so, I would say you need to try and look for other ways of supplementing it.
Cool. So let's chat a little bit about bone density and the periods of bone density where people are a little bit more risk. And perhaps that's relevant to sort of the peak bone mass, because if you don't achieve your peak bone mass, then things, you know, you're losing bone density at about a rate of maybe 1 to 2% a year. But during menopause, that's much faster.
Yeah, much faster,
So from a hormonal point of view and from a bone health point of view, what happens during that period?
Of menopause?
Yeah.
Okay, so, well, menopause is effectively when the menstrual cycle stops, periods stop. And that's because the ovaries retire. And the ovaries produce the two key hormones, the estradiol that we mentioned already, and also progesterone, by the way. So menopause is when the ovaries retire, which is fair enough. They've been working very hard. You know, ovulation, hopefully, and producing these hormones throughout the woman's life. So at some point they retire, and that is what the crux of the problem is. Because the now lower levels of these ovarian hormones, that's going to affect many aspects of a woman's health and well-being. Not, by the way, cardiovascular health as well, but specifically for bones, we know that's not good, because now you've got really low levels of estrogen. And in contrast with men, there is a slight decline in testosterone, but not that dramatic drop. But still, there is a bit of a drop. But also for men and women, there's another hormone we should mention that starts declining with age, over 50 onwards, and that's growth hormone. Growth hormone, by the way, it's not just about teenagers growing, but it's also, even as adults, we still produce some of this growth hormone, and it's what we call an anabolic hormone, builds muscle and bone. So for men and women, there's the decline in growth hormone. There's a little bit of a decline in testosterone in men, but women have the double whammy of the decline in growth hormone and quite a dramatic decline in estrogen production. So that's what the crux of the issue is.
And so the loss of estrogen sort of accelerates potential bone loss. And this starts in the phase, sort of that perimenopausal phase, because it doesn't just switch off
No, exactly.
It's a transition.
Yeah, so perimenopause, it's like you're in the waiting room. It's the transition from having regular periods to menopause. It's not an on-off switch, like you say. So perimenopause is basically that sort of the ovaries are going part-time.
Yep.
So some cycles will be fine. There'll be enough estrogen and progesterone to go around, but then other cycles will be on the wane.
Yeah.
So already during that stage, you're right, there will be some impact on the bone health, but it's really the significance is when, you know, the ovaries officially fully retire, and that's it. But one of the things is during perimenopause, because of this big fluctuation in the hormones, the woman might not be feeling so good, you know. She's got hot flushes, she's feeling low in energy, she can't sleep.
Joint problems,
all sorts of things. And guess what? And we're saying to people, you need to go and exercise and do your strength training and everything. But if you really, it's quite a struggle. So that's another aspect to it. It's difficult to find, as you say, the struggling with aches and pains and motivation. It's actually quite challenging.
I mean, so we treat lots of different individuals, and from elite athletes to young kids, but those postmenopausal women are one of those groups, and lots of them respond very favourably to HRT in terms of how they feel, how they function, and also how their body feels in tendon function, joint function. HRT is very beneficial from a bone protective point of view. Is it not?
Yes, I mean, the main indication for a woman in perimenopause, menopause taking HRT is for quality of life. So all those symptoms that is just dragging her down, then absolutely that's the main indication for HRT.
Okay.
But HRT, hormone replacement therapy, which typically for a woman means some estrogen and some progesterone, or progestogen, should I say more correctly. You know, this HRT is now the primary medication for both the prevention and treatment of poor bone health at any age.
Yep. Okay.
Because that's
for females.
Yes, of course. We should say that, for females. So this is really interesting because, you know, there will be some younger women who haven't yet reached menopause who might be experiencing REDS, the relative energy deficiency. Their periods have stopped. They've got very low levels, therefore, of estrogen and progesterone. And in this case, you know, while you're trying to get their periods going again, if you're really concerned about their bone health, they've had stress injuries already, bone stress injuries, and all from their DEXA scan, they've got, you know, indications that they're at risk of, you know, really poor bone health. And actually, we would give them some HRT just for a little while to improve that. But for the older woman, perimenopause, menopause, definitely the main indication is quality of life. But also now we've got this extra indication for poor bone health. If we know we've got evidence. Well, number one, that if you get a fracture at that age, hopefully you would get a DEXA. So if you got the evidence of a fracture and you've got, you know, the bone health isn't looking so good, then definitely HRT would be helpful.
Yep. Okay, cool. So, so HRT offers this nice sort of protective factor.
Yes.
And clearly that's a personal decision that females should discuss, but you clearly are in favour of offering that as a possibility for many clients where
well, definitely I would, like you say, I'm not in the job of forcing anyone to take anything,
Yeah.
but I would explain the pros and cons, and here are the pros. Right, this will help with your symptoms, and it will help with your bone health if we're worried about that,
and cardiac
and cardiac if you take it within 10 years of menopause. And it decreases all-cause mortality. So, you know, there are definitely some pros for it. The cons are, I'm also open and say, yes, you know, breast cancer, it increases extra 4 cases per 1,000 women, right? But this is exactly the same risk as taking the oral contraceptive pill. And if you're doing 2.5 hours or more of exercise per week, there's a decrease of 7 cases of breast cancer. So if you do your maths, right? But ultimately, I'm in the job of giving the facts, the figures, and then the person makes the choice. And if they say, okay, I want to try it, then we go on and explore what are the best forms, because there's a whole range of different types of HRT out there. So then we talk about, you know, what the best ones are, and always it's the lowest effective dose. We don't go in there massive high. So, you know, it's tailored for the individual, but ultimately it's their choice. But they've got to make that, in my opinion, it's so important for anybody to make an informed choice. So I want to make sure they get all the facts, they have all the facts, and so they can make that informed choice, not based on something they've read on social media.
Yes, and there's been lots of out there about HRT in the past, but I think we're moving hopefully a little bit away from
more
that.
sort of balanced view. Yes.
Yeah. So what is the thyroid and adrenal, how do they impact bone health if there's potential problems with some of those hormones that...
Yes, so I'm glad you brought it back to hormones and the fact that hormones interact, and also they've got multiple effects.
Yeah.
So let's talk about the thyroid. So the thyroid gland lives in the neck and it controls your metabolic rate.
Yep.
And so if someone has an overactive thyroid, it's producing too much, then actually it speeds up the whole body, speeds up all the processes in the body, right? And this could include bone turnover.
Yep.
So if you don't treat this over enthusiastic thyroid, then one of the symptoms could be, or outcomes could be, poor bone health. So we need to bear that in mind. And similarly for the adrenal produces a hormone called cortisol, stress response hormone. But again, if that gets over enthusiastic and starts producing, it's similar in some ways to the sort of the thyroid hormones. It sort of speeds everything up, gets you on a high alert state. And again, cortisol, because you're in high alert, a low priority is your bone health, right? So again, that could potentially, if you have a medical condition, that could potentially impact bone health. I mean, fortunately, hiccups in the endocrine system are relatively rare, but it should always be a consideration. Someone presenting with poor bone health, just especially if there are other symptoms that are suggestive of overproduction of thyroid hormones, for example, then it's just important to tick that off.
Okay.
That's all good,
And that's running some standard bloods.
Yeah, so just standard blood test.
Which would help to identify.
Yes, exactly.
Yeah. Okay. And so there's a couple of ways that we can investigate sort of bone health. DEXA is sort of the gold standard.
Yep.
We use in our clinic Ecolite REMS as another option, because it gives you bone density plus also bone quality, or that fragility of bone. They're the two sort of markers, really. Can you just outline a little bit about what you're looking for on when we're measuring those?
Yeah. So the DEXA scan, which stands for dual X-ray absorptiometry. Yep. But it's a very low X-ray. It's not like it's a teeny fraction of the X-ray standard dose for a chest X-ray or something. Anyway, so as you say, this is the gold standard. It's been around a long time, and essentially what it does, it looks at two particular sites, standard sites: the lumbar spine and also the area of the hip. Yep. And the reason for looking at these two sites is that the lumbar spine is a certain type of bone, trabecular bone, rich, whereas the hip is slightly different cortical bone. So there are slightly different, things that impact those two sites. Of course, estrogen in both cases, but especially for the lumbar spine. So the DEXA scan, if you've ever had one, it's quite straightforward. You lie there, and a scanning machine about the size of a suitcase just passes over, your hip and your lumbar spine, and then it produces some beautiful, pretty graphs at the end. And so you'll get a readout for the lumbar spine and for the hip. Yep. And there will be an absolute measurement in grams per centimetre squared and a number. Yes. But then it's like, well, what does that number actually mean? Yeah. So then we have two other metrics which give you some sense of what that number means. Yep. And that's called the T-score and the Z-score. So the T-score is comparing your measurement to the peak. We mentioned peak bone mass earlier. And that's the definition of osteoporosis. So if you're a long way below the peak, right, to the tune of 2 standard deviations or more negative, then we say you've got osteoporosis. That's the measurement used to define osteoporosis, and but the problem is it's only really used for people over 40. Yeah. So what do we do if we're scanning somebody that's under 40? So then we look at another one, the so-called Z-score. Yeah. And that is a score looking at your measurement relative to someone of your age. And so that is more relevant if you're under 40. For example, the athletes and dancers I'm dealing with that have REDS, relative energy deficiency in sport, I want to know what their measurement is. Is it much lower than we expect for their age? And the same sort of principles apply. If it's a negative score, typically below -1, for example, in a woman, then this is an indication maybe for giving some HRT to help the bones. So that's what you get, the information you get from the DEXA. And that's actually, you know, we've got lots of data on it, and also depending on that reading and some other factors, you can calculate, you know, there's a thing called the FRAX score, and you get to your risk of getting a hip fracture in the future. So that's the gold standard, as you said, but it's really exciting. The new technology, the REMS technology, which I won't try and remember exactly, it's radio frequent. Basically, it's a fancy ultrasound. I'll leave it at that, all right?
Yeah, it's an AI-driven sort of ultrasound.
It's a fancy ultrasound. So the big advantage of the ultrasound is that there's no X-ray radiation involved at all. And the other thing is that it's, you know, DEXA machines are in a hospital, whereas there's
not an abundance of them.
And also, it can be a bit of a bum fight to get one. That's true. So the advantage of the REMS is no radiation at all, and also it's a portable machine, so you can take it around potentially. And we did a study actually of it, and I took the machine there and was wheeling it around and all that sort of thing. But it measures the same sites, the same gold standard sites in that sense, the lumbar spine and the hip. So we get the same metrics that I said, an absolute measurement, the T-score, the Z-score, which we now know what those are. But as you mentioned, Simon, really important, it gives us an extra dimension, literally. It tells us the fragility score.
Great. So touching back on the bone quality and bone fragility, I slightly liken it to a brick wall, and osteoporosis is having a few bricks missing in the wall. But the bone fragility is having poor sort of cement in between.
Yeah, and also it's almost an idea of...
Or in between the bricks, I should say.
Because, you know, the wall could look a little bit dodgy, if you will, but actually I look at it like the structure, and also now what happens, you know, if you gave it a push, it might still stand up. But it might not. So it does definitely add an extra dimension. And going back to, you know, we were talking about developing peak bone mass, that is about the mass of the bone and the bone mineral density. But actually, there's another element to it. There is the microarchitecture. So this is why the REMS is exciting, because it's giving a nod and accepting. Exactly. It's not just what it looks like and this measurement, this literally dry measurement of the bone mineral density. It's actually saying, how is it put together? Could that wall... maybe the wall is okay. Maybe actually, but it could work both ways, couldn't it?
Exactly.
It could be that actually the bone mineral density isn't great. There are some holes, bricks missing, but actually,
you know what? Okay.
You know, the cement is actually doing a good job and it's together, or it could be vice versa. So it gives a little extra dimension and a little bit more insight, and so I agree. That's really interesting.
Yeah. Okay. Cool. And I suppose the big question is, we can reverse this, can't we?
Hooray! Yes, we can indeed. I mean, it does get harder. I'll be honest. Let's be frank. It gets harder as you get older. So we've already said that at the young age in particular, when you've got the driving forces to make bone, that's great. Right? And once you've, as an adult, for example, individuals that get REDS, relative energy deficiency, and their hormones are low, so they're at risk of losing bone. We can, if we can get them, you know, the rebalancing their nutrition and their exercise, get their period starting again if they're a female, or a male, get their testosterone up, then we can make good those losses. But the same principle, and the fundamental thing to remember that we started the conversation with, Simon, is that bone is a dynamic tissue. So we can. Okay, the seesaw may have swung in favor of breaking down as we get older, but you can try and rebalance the seesaw, right? And so you can do some positive things to encourage that rebalancing the formation of the bone. So when we talk about, the only thing I would say, reversing osteoporosis, I think improving bone health maybe, because we can't guarantee, we don't know exactly how much we can reverse it. And what are we aiming for? Reversing to what? We definitely, let's be frank, we can't reverse it to, you know, the peak bone mass. That's unlikely. But we can get you out of the risk, out of osteoporotic range, and get you improved.
Which is back into sort of, because normal range, and then there's osteopenia.
So we could improve, we can definitely improve. So reversing from osteoporosis and improving, And, you know, it will be individual
and
how far we can go with that.
And because also actually keeping someone stable
it's better
is
than
also
nothing.
a massive improvement.
Yes, because if you do nothing, like you don't, you know, look at your nutrition, do the exercise, and maybe not take HRT or whatever, then I'm afraid that it is inevitable. You will continue to lose bone. But so even if we could hold it stable, that would be something.
Yeah.
But hopefully, and there are good studies to prove it, are there not?
Exactly.
That we can actually do better than just holding it stable. We can actually improve it. Wow.
Excellent. Okay, I love that you're saying that, because we have sort of built a system in our clinic based off some amazing trials out of Australia called the Lift More trial.
Yes, exactly.
And we've spoken about it lots. And the Lift More trial is a particular group of trials that showed that some four key strength exercises, and we're talking high strength exercises, help to reverse or improve bone density.
Get them out of that.
Yes, in osteoporotic females.
Yeah.
That was the first. And these are 4 sort of exercises, like a back squat, a deadlift, an overhead press, and then a jump.
Yeah.
These are these the key things, do you think, to be doing typically at a later age for muscle health, for bone health, for optimizing a lot of other factors?
I mean, by the way, I do love the name of the study. The clue's in the name, Lift More.
Yeah.
It does what it says on the tin.
Exactly.
But the really fascinating thing was that they had, didn't they? They had the 2 groups of women. You know, one group, they just said vaguely do some exercise.
Yeah, some standard sort of exercise.
Yeah, you know, things like this. And the other group, they gave specifically, like you say, supervised.
Yeah.
And quite beefy, quite, you know, weighted. You know,
I mean, they were lifting, I think it was 5 sets of 5.
And they were in their 60s, were they not?
Yeah.
So, you know, and this is the dramatic difference between the 2 groups, like you say, is that one group, the one that just sort of did some vague thing.
Yeah.
They lost height, as you would predict, lost bone mineral density, as we said, you know. Whereas the others, like you say, it was totally the opposite. They improved their bone mineral density. They didn't lose height.
And some of them actually improved their height.
Oh, yeah, as well. Right, okay. But they certainly didn't lose it, but if anything, improved it, and they improved their bone mineral density. But I think the thing is, so when you're doing these strength exercises, you're doing them directly for the bones, the osteogenic effect, like we said, but also you made an important point about the muscles. You got to use the muscles. So remember, I mentioned that muscles pulling on bone is very good. And also, as we get older, not only are the bones potentially, if we do nothing, deteriorating, but frankly, if we do nothing and just sit there, then your muscles will weaken as well. You can get what's called sarcopenia, loss of muscle mass and weak function, so you can't get out of the chair without pushing down, things like this.
Sort of bone density decreases over, you know, maybe 10-12% every decade.
Yep.
Muscle strength does the same
absolutely,
thing.
absolutely.
It follows that same pattern.
So the benefit of doing the strength exercise is, yes, directly for the bone, but also as well directly for the muscle.
Exactly.
But then the 2 communicate.
Yeah.
You've got strong muscles, you can pull on the bones, and they both get stronger, as it were.
Correct.
So I think that those are the sort of the key movement patterns and things like this. And the other important point I think about these studies is that, you know, if you know you have got osteoporosis or or osteopenia or basically, and you're of this age in your 60s and you're thinking, you get really scared. You get scared. It's like, oh gosh, I don't want to even lift up my suitcase because something might snap. And you actually put yourself in cotton wool. Yeah. But actually you should be doing the opposite. But this study is encouraging because none of them, in fact, they improved their bones. They didn't get any injuries, you know.
And the sort of subjective feedback was that they all felt amazing.
They felt good.
They felt a sense of resilience and sort of strength because they could do things, a lot more vitality for life.
And also it would help with metabolic health as well because doing strength exercise engages all the muscle groups, like we've said. And this helps with blood glucose control and other things.
Because your muscle system is the biggest.
It grabs it all. So this is why they were feeling more confident in themselves and all that sort of thing. Yeah. And a similar study in men, I think they were even older. I think they were in their 70s. You know, when they did the little jumps, they did just a few hops every day. Nothing like loads and loads. And they also similarly had benefits. So I think that's the other important psychological piece to this. Sometimes we get worried, or we put ourselves in cotton wool, understandably.
Yeah.
But actually, it's the opposite. And these studies should give confidence to people that you can do it safely.
Exactly.
Guided, except you do in your clinical setting. It's all guided and scheduled and programmed and progressive and all this sort of thing. So you have the confidence, okay, I can do this. And then you see the benefits of it. And then it's a sort of a self-fulfilling prophecy.
Exactly. I mean, because there's a couple of interesting points that, one aspect to this is that when people have low bone density, they lose confidence.
Yes.
They have inherently lost strength along the way, and they
Yes.
fall. And why do they fall?
Yeah,
Because,
exactly. Yeah.
Okay, they've either lost power to be able to catch themselves, or they lose balance.
Well, yes, if we can just say that, there's the Royal Osteoporosis Society. I love their pamphlet. It's called Strong, Straight, Steady.
Yeah.
So strong is obviously the strength, right? Yeah. Straight is posture.
Yep.
Everyone falls off at that point. And steady, balance. So it's a multifaceted thing.
Yeah.
Yes, you need really strong bones and strong muscles, but also some balance
Very good balance,
exercises.
yeah.
So proprioception, so the standing on one
And
leg.
that's the feedback
And
through the system.
exactly. So awareness of where your body is in space, and everyone can do this.
Yeah.
I mean, I do
It's simple.
suggest. By the way, when you do
Brush
it,
your
I do.
teeth and-
Yeah, but I do suggest if you're
Yeah.
starting with this for the first time,
Yep.
do make sure you have got something you can hold on
Correct,
to.
yeah.
But it's quite difficult just standing on one leg for a bit.
It is.
It is
Yeah.
actually quite difficult, but that's fine.
And there's pretty good evidence that not being able to do that for more than 10 seconds
Yeah.
is a big red
Risk-
flag.
yeah.
And it's a risk factor, and it actually is highly correlative to sort of longevity.
Yeah, exactly. So there are these elements. There's the strength, yes, for everything like we said, the posture, yes, but the balance and all these things will interact
And weave into each
together.
other. Yeah.
Together. So I think that's the other thing that people hear a lot. Strength training, weight training, and I have to be honest at this point. I don't like weight training,
Yeah.
right? And so
Because
can
it's
be
scary for
because it
people
can be
to go into the
because
gym
it
for
can
the
be
first time.
it can be a put off. So you're told, you should do weight training, and if you're like me, it's like, number one, I hate going to the gym.
Well, you're an ex-dancer.
I know, but I go to the gym to go swimming, but I wouldn't go into the gym and I would lifting weights. It's like, well, and it just doesn't interest me. So even if I went and I did a session, I know that I haven't got. It's got to be something that motivates you and that you will repeat. There's no point doing it once and think that's it.
Yep.
It's got to be something that you enjoy, something that you feel confident about and good about, and that you do.
Yep.
And I think because there's so much emphasis on weight training, we've forgotten there are other ways of strength training.
Yeah.
We've also forgotten that actually, doing other things like the balance work and all this sort of thing, it's
All
got to be
makes a
all
difference.
this combination of things is
Yep.
really the key thing.
Yep. And I think you touched on it before, that we advocate people doing a mixed sort of pattern, play your tennis.
Yes.
Go and
exactly.
be active. But when you are doing your strength training, you need to, because you need to get to very good loads.
Yes.
And we're talking high loads that these studies suggest, because simple body weight exercises are probably not enough stimulus ultimately. So it should be done. You should have someone guide you.
Well,
and
definitely you need
overload.
it exactly. So it's a progressive thing. So you're right. I mean, body weight exercise is better than nothing. That's a starting point.
Yeah, completely.
But then absolutely, as you said, these studies show the evidence is you've got to actually load it quite well. And in the studies, they were all supervised, weren't they, these sessions?
Yes,
Simon?
they were.
So that's why your program is so good, because it will be supervised, so you can be reassured you're not going to get injured, number one, the first thing. And also, it's progression. The body responds to differences. If you always give it the same look, it kind of gets bored.
Exactly.
Right?
Yeah.
So you've got to give it a little bit of a
different
challenge.
stimulus.
Give it a little bit of a challenge. It's like, I've got to work a little bit harder with this bone mineral density because now I'm being asked to lift this slightly heavier weight or something, whatever it is. So it's definitely weight training. Let's be honest, that is the ultimate goal, but with the proviso that it's got to be in a proper supervised way, like you do in your clinic, and with progression, and also, by the way, with love and enjoyment, if I can put that point.
If you can.
No, or a little bit of enjoyment, but I think having that encouragement and also seeing that you are progressing.
Yeah.
That's a feedback in itself that you'll be able to stick to it and get enjoyment from it. Because,
Exactly.
So that's
and
really what it is.
Feeling better along the
Yes,
way,
exactly.
which you should see.
Mm.
So I think the studies showed that, twice a week was all you needed to do
Yep.
to make this sort of change. And we use another machine in our clinic called a biodensity machine, which is just high.
I've tried it.
Yeah.
It's tough.
It is.
It's good.
high sort of isometric load into the system, which also has been shown to build bone density. So there's lots of different avenues and approaches people can take. But I think the key message is that don't wrap yourself in cotton wool.
Yes, you've got to do something like that.
You've got to do something and start at an appropriate level for you,
and
and gradually build
and
that
build
up.
Exactly.
Yep.
Yeah.
We've sort of mentioned REDS a few times, and there's the other spectrum of we've been talking about osteoporosis and bone density issues, but lots of other people can have problems with their bones, so stress fractures or overload type injuries, or perhaps their system not functioning well because they don't have enough energy in the system, which is what REDS stand for, so relative energy deficit syndrome.
Yeah.
That's not just for sports people, though, is it?
No, I want to really emphasise that. I mean, unfortunately,
or just for females, actually.
No, correct. We should. It's a shame they started. REDS is relative energy deficiency in sport, but I wish they were. In some ways, I wish they just take out the sport bit of it, or they made actually I mean, it's a very small detail, which probably only people that sort of like me that love detail would have noticed, that it used to be a capital S, but now it's been downgraded to a small s.
Okay.
So, which is some nod and acceptance that this is not just affecting these elite sports people. In fact, it's unlikely to be the elite people, because the elite people will have a doctor, a nutritionist, a physiotherapist, a whole raft of people supporting them and making sure this doesn't happen. But it's more the enthusiastic exerciser, and we are encouraging people, are we not? And we should do to exercise more. But sometimes when
rest and recovery is
exactly. So if there's
important.
So if there's too much training load, but not enough of the number one, the rest and recovery and nutrition to meet your demands, that's what the problem is. But by the way, I just want to say about that rest and recovery piece, because when you ask someone how much exercise or are you doing, what you're training, what's your training schedule like, they all want to tell you about the doing bit. But I want to know about the bit when actually you're getting fitter, which is when you're resting and asleep. Because what's making you fitter? The hormones, of course. They're driving positive adaptation.
Your favourite.
My favourite. But they need a chance. They need some breathing space to do this in. And typically it's when the main stimuli, we mentioned growth hormone, the two main stimuli for growth hormone release are training, exercise for sure, and sleep. Guess what? So you need the combination, and you need it matched with rest and recovery. And I'm renaming the rest and recovery day or sleep. I'm renaming this the positive adaptation time. Because that's when you get fitter. So of course you've got to put in the work, it seems obvious, but you've also got to have the rest. So, but sometimes people get too enthusiastic. They forget the rest bit, right? They're training a heck of a lot, and they've probably also got a job, so they're running around, lots of pulls on their demand, so that's a stress in itself, but also they're not matching that with the energy demand that this takes. So that's where the energy relative deficit. So they might be what seems like they're eating a reasonable amount, and the same as their friend sitting next door who is not doing any exercise, but it's relative. Their demand is much higher because you need energy to fuel moving around.
And when we're talking demand, we're meaning metabolic demand.
Yes, metabolic demand for the muscles to do their thing. And the interesting thing is, from an evolution point of view, our energy intake is prioritized to movement because we used to have to run away from predators. So people come and say to me, look, I'm not feeling so good, but I'm able to exercise. I'm able to go out for this early morning run every day. I can do the exercise. So how can I be in energy deficit? And I say, because your body's clever. It's prioritizing that, but it's got to come from somewhere. And so it's going to take energy from other places.
And your skeleton is one area.
And the skeleton is one place where we've told it's an active tissue. So it's like, well, we can save energy on not doing that business, as it were, and switching off the reproductive axis or dialing it down. So this is why their periods stop. The men get lower testosterone. And so then everything starts to unravel. So your body is adapting, but not in the way, frankly, you want it to. You want it to be a positive adaptation, but actually this is it's a quite reasonable adaptation from the body's point of view. It's preserving you, keeping you alive.
Yeah.
Right?
Well, it's a survival based on a survival sort of
a
mechanism.
mode. But ultimately, like you say, one of the first systems to be affected, this is really interesting, is the bone.
Yeah.
The bone is the first one where you start to see those adverse effects. So, and potentially they can be quite severe. If this is happening in a person under 40, then we're going to be using that Z score you mentioned. But we've got this indicator of when it becomes negative relative for their age, and they might be getting injuries, bone stress injuries, because you're trying to load this skeleton, but the skeleton hasn't been able to adapt. It's switched off, remember, right? And it's not so healthy. So now they're getting stress injuries, bone stress injuries, and the DEXA will be not so good for the age. So basically we've got a problem. But the good news is this is reversible because it's an adaptation. So we can reverse the adaptation. We can flip the switch and get back to it being a positive adaptation. But that is difficult, challenging, because I'm asking somebody to change their behaviors. I'm saying, look, I admire you for doing the exercise, but number one, you've got to have more rest and you've got to eat some more to fuel it. So it is possible, though.
We see more and more of this, I think, whether it's London life, whether it's our modern life, because people underestimate life load. Like you touched on it before, as in they might be training, but they're got a high power job.
Yeah, exactly.
And they're caffeined up, but they're not. They might miss a lunch here and there.
Yes, exactly.
And, their energy demands are probably significantly higher than someone who's just sitting on their backside the whole day.
Yeah, exactly. So it's the combination of stressors.
Yes.
The training itself and the energy demand, metabolic energy demand for that, but then also, most of these people also, like you say, a full-time job, which might involve travel, by the way. Different sleep schedules. Sleep's very important. I think we mentioned that, right? Okay. And there's a particular study saying poor sleep actually has a direct effect on bones. No surprise, because we've said that hormones work their magic when you're asleep. So if you're not sleeping, then anyway. So you're right, it's these combination of all these things that could result in REDS, and that's why I go back to my initial comment, that this is more likely, I would argue, to occur in people who aren't professional athletes, because they're not professional, so they've also got to hold down a job. They've also, family stuff, other demands, who knows, there are all sorts of other stressors in their life that's going on. So it's a case of, I don't like the expression balancing hormones, because the hormones just respond and react to what you're doing. What really is at the crux of the matter is your balance, you balancing all these pulls and pushes, which, it's not easy, but it's definitely possible, and more to the point, it's essential if you want to be healthy.
So what are some of the warning signs, or are there early-ish warning signs that people can watch out for to try and get that balance of load, rest and recovery versus life load, exercise load in the system?
Well, I think the first thing is just be honest with yourself and just sit down and think about it. And if you're feeling really tired and frazzled, just sit down and look at it. And this is often my job. People come and I say, well, just walk me through your typical week. And then I said, well, what does that sound? Now you've said it out loud. What did it sound like? And they were like, oh, yeah, you're training every day. You're doing it early in the morning. You're not having breakfast. You're rushing into work, not eating anything. And you've got to, you're burning the candle. You're going to bed late. It's like actually. So the first thing is just to take a step back. And if this was somebody else telling you, this is what this person's doing, it's like, that sounds a lot.
It's amazing how people can slip into that.
Yeah. So it's just feeling frazzled, and also actually poor sleep in itself, because if your body is in this high alert state, and especially in low energy availability, it disrupts sleep because your body's making you wake up to seek food. I had one person come and see me and they said, oh, I keep waking up with this dream that I was looking for a pizza. It's like, I think your body's trying to tell you something. So, poor sleep, just feeling lacking of energy, lack of concentration, because the brain needs energy. The brain is greedy. It takes 20% of your energy intake, and it needs a lot of hormones, by the way. So, this could be just, you're just feeling really frazzled, can't concentrate, poor sleep. Specifically in talking about the reproductive hormones, of course, a woman, her periods becoming irregular, stopping, For men, would be lower testosterone, therefore reduced libido.
And
so these are things to look out for.
Because a lot of those things, may well be obvious, but also performance suffers as well.
Oh yeah, that's the really interesting thing about REDS, because it's made before REDS was first described by the IOC, International Olympic Committee, 2014. Before that, we only had what's called the female athlete triad, which there's obviously a problem. Number one, it was only for women. And number two, it was just these three things of, no periods, poor bone health, and disordered eating. But then, and it had no mention about performance. So REDS explains that this imbalance in behaviors will result in many health consequences, poor bone health, low hormones, etc. But also, crucially, it says, it describes that because your hormones are now low, you can't perform to your best. You'll still be able to run, like I said, because your body will make you, give you the energy or prioritize the movement. So you'll be able to run,
to go and
do things. So you might kid yourself, I'm fine. But actually you just can't get the benefits from that exercise effectively. So you'll be frustrated. You're getting slower running rather than faster. And actually your pulse rate, rather than going low, is now getting higher. So things aren't going, like your performance suffers.
Exactly. And so sometimes we see sort of people's resting heart rate sort of increase, or the HRV will actually drop a little bit.
Exactly.
So an HRV is heart rate variability for people, which is a measure of stress.
Yeah, exactly.
Essentially. The other flip side of that, if people aren't quite aware of their performance suffering, is actually little injuries and niggles.
That's a very good point. Yeah.
The body not functioning well and not being able to heal.
Yeah. So, of course, the bone stress injuries will be an obvious thing, but also, you're right,
and
soft
sort of
tissue
stress
injuries.
Fractures that we're talking about.
So, yes, it's a whole, just maybe bone edema, just feeling uncomfortable, but then it could even progress to a bone stress fracture, you're right. But also, Simon, you're right, it's important to emphasize, the hormones are low. Did I mention hormones? Anyway, so you can't, you're more likely to get soft tissue injuries as well. So niggly things like, everyone gets a pulled muscle from time to time, but you keep getting a pulled muscle, it just won't recover, or a ligament or a tendon injury that just won't recover. So any, like you say, niggly injury that just keeps coming back, or you keep getting re-injured all the times, of course you have to look at the biomechanics and say, are you wearing the right trainers and all this sort of thing. But
if it's not a mechanical
or
a load issue,
there must be something else going on. Yeah, exactly.
And how do you map out this return to function for people? Are you, when they have REDS, and I'm sure everyone's independent and or different, but generally a lot of the time they need rest to deload initially, to allow their system to recover, but perhaps also, let's get a nutritionist on board. Let's look at your protein, your carb intake, to make sure that you're optimizing that.
Yeah. Well, actually, if I'm okay to mention one thing, if people are wondering, have I got REDS, or I'm on the verge of REDS? We developed a new online questionnaire, free.
And what's that questionnaire
It's called the PEAK, which stands for Personal Energy Availability Questionnaire.
Cool.
And so you can go, and it's a little web-based app. So you click on it, and there's some questions for women and for men. You click on whichever is appropriate. And then I think it's about 15 questions. Very straightforward, just asking your age, how much you're training. If you're a woman, yes, we will be asking you about your periods, asking you about injuries, asking you about any digestive issues, which is, by the way, another thing, and basically getting a feel for your attitude towards fueling and things like this. And then you click these questions, and then instantaneously, as if by magic, then you get a downloadable report. And it gives you a risk score.
How accurate is that?
Well, it's based, because the questions are all weighted. Your answers will give you a score, and also the score is broken down into the components of physical, physiological, and psychological. So you can see actually which areas is particularly troublesome. And this is validated questionnaire. This questionnaire is something we developed From our research, I mentioned the male cycling study. We've done studies in dancers, and the male cyclists, for example, included bloods and DEXA scan.
Yep.
So, and also some of the questions, to be honest, are already in other validated questionnaires. So we're on pretty strong ground that it will. I mean, it's not a diagnostic tool.
No.
Right. So that's obviously a thing, but it gives you an indication. Where are you on this dial?
Yep.
You know, because symptoms could be due to other things, like we said, an underactive thyroid.
Yep.
So, but it gives you a feel. Are you at risk or what's going on? And then it will give you some direction.
Exactly.
And also some reflection, because as you're filling out these questions, you might think, oh my God, I've just said that I avoid carbs. So the penny might drop as you're filling in the questions. So it'll give you an indication, and then you can take that downloadable report and if you want to show it, whoever you want to show it to.
Yeah.
So then, for example.
And it might help you to determine, okay, right, now's the time to go and see someone.
Yes, it might push you that way. So. So now anybody that's coming to me, I ask them to fill out this questionnaire, for example, just so I get a feel for what's going on. And then, yes, how to approach it. So say we now have come to the conclusion that, this is REDS, and I would always do blood tests to make sure there isn't something wrong, like a thyroid or something medical. But let's assume that this person, yes, it is because they've got this imbalance. So what are we going to do? So the first thing is to be honest and say, look, well, the good news is we can fix this, right? And we can make you feel better again and improve your performance. But it is hard, especially if this was an intentional thing, because I'm asking them to change their behaviours, which is really hard.
Behaviour change is hard.
So I know. So the first thing, like you said, is the rest element.
Yeah.
You know, let's just dial down the intensity of the exercise. And people will be relieved here. Rarely I say stop all exercise, but definitely I will be. Especially if you're training, I'm just warning you, training twice a day and all
stuff, cardio.
So we'll just tweak it. We'll keep the strength work in there, absolutely. So we'll dial down the intensity of the training. Also, I'll just give them some fundamental baseline for the nutrition guides. And I know this sounds very simple, but 3 regular meals a day, right, with carbs and protein. And also, any exercise you are doing, make sure we're really fueling appropriately before, during, and after. And that's especially important for bone health. So I give them the guides of the nutrition. If they want it in more detail, then yes, absolutely. I've got colleagues, and we will need a dietitian, Nicola Marsh, of course. You know, if they need more detail. But some people, they're actually good to go if I just give them those sort of guides and to see how it's going to work in terms of the training and the nutrition, and you know, we see where we go from there. And also the DEXA, if we're worried about their bones.
So is there a blood test or a series of tests that you can use to suggest that someone's, or is this more of a clinical diagnosis?
The first thing is definitely clinical. But then absolutely we absolutely have to do the blood test. Mainly to exclude other medical things. Right? Because this is a functional adaptation. It's not a medical condition as such. So we have to do the blood test, number one, to rule out anything like funny with the thyroid or whatever. But also the bloods in themselves also are helpful in giving us an idea of this risk stratification. For example, one of the hormones we have to do is T3, one of the thyroid hormones, and this is a primary indicator of REDS from the IOC consensus statement. So the bloods are twofold: to rule out stuff, and also to give us an indication of degree, right? And for a woman whose periods have stopped, the blood test will also confirm that the periods have stopped because of REDS and not for any other reason. So the blood tests are, well, yes, they're essential.
Okay, cool. That's super insightful. What we haven't touched on yet is sort of screening, and I'm going to flip back to bone health a little bit. For screening for bone health, I mean, the NICE guidelines, I don't think push this far enough. And we're sort of advocating that almost everyone over 40 should be screened for bone health, because it is something that people can do something about.
It's preventable, isn't it, for it to get worse. And also, frankly, we know that it will be decreasing for the reason it's going to
beyond 30.
So it will happen physiologically. We know it will decline, but we don't know for everybody where their starting point of decline is. And also the rate of that decline. So there are lots of things we don't know. So I agree with you, but it should ideally be screened. But of course, the problems are that if you're talking about DEXA, as we said, that's labour intensive.
Availability,
We can't.
costs,
To be honest, I don't think that is the solution. And there is, there is a sort of a screening questionnaire, the FRAX, without the DEXA. You do, and we actually developed a slightly more in-depth bone questionnaire thing, using when we combine that with the REMS thing in our study, which maybe we can give in the show notes or whatever you're doing. Anyway, definitely. So it's not as sophisticated as the peak. We haven't got that as an automatic app yet, but you can have a look at the questions and you can answer them and get an idea.
Cool.
So just getting some ideas of where you're coming from and some risk. And then, yes, let's be honest, getting a DEXA is challenging. But a REMS would be a reasonable thing to do because it is more accessible. You can self-refer and get that.
Because people bury their head in the sand.
Yeah, I know.
Don't want to know.
We all do. I mean, I understand, but it's better to know and be able to do something about it. Yeah, exactly. Better to know rather than, and also it's scary wondering. And earlier, the sooner the better. And it's not going to go away just because you try and ignore it. And actually, I find it's more. I mean, my character is I want to know because otherwise it goes round in my mind and you start getting scared and wondering. So actually, I would advise all people, you might be good, it might be bad, but the thing is, at least you'll know, and one way or the other, and then you can do something about it. You direct your action depending on that, and also then, especially for the REMS, you can do a follow-up. And that's nice positive feedback.
To know that you're making some change.
Yes, that makes a difference. And that's the other thing about the DEXA. If you do manage to get DEXA, well, first of all, congratulations. But secondly, the earliest you could do it would be another year, right? But actually bone reacts much quicker than that. We know that from our study with the male cyclists, where it was a research thing. So we were allowed to do a DEXA after 6 months, and we saw that there were changes within, and also, I believe, for the Livermore study. So, we know that bone actually changes
completely
more quickly than that, but it's just because of the limitations of the measurement, blah, 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 that we can't do that. So I think people informing themselves and taking control of their destiny, that's the thing. You advocate for yourself and you feel you've got control and agency over this. I think that's always the best way to go about it.
Yeah, amazing. I think this has been super interesting and fascinating to discuss this with you today, Nicky.
Well, thank you. I've enjoyed it as well.
It's been, great, and a super important subject, I think. You published several books or written several books. You published widely. People can come and see you.
Yeah, sure. All of the above.
Yeah.
I've done many publications. I mentioned a couple of them. And if people are really interested, they can go and look at my website and look at the papers.
And we'll put that in the show notes.
Yeah, and please look at the peak for people for that. And then my 2 books, there's Hormones, Health and Human Potential. Well, it kind of tells you what it does. It talks about hormones, right? And also more recently, Myths of Menopause, which was a fun one with some myth busting there. And as you say, I also offer advisory appointments, Simon. So for anything really, in the sense, anything to do with hormones, the REDS piece or the perimenopause, menopause, navigating that journey and discussing HRT, those are the things. Because, these are things that should be readily available on the NHS, but we know the reality of it. They're not, and also the time. So I will talk to you in depth for 40 minutes. We'll go through everything in detail and we'll come up with a plan. So I offer that. So if people are interested in looking at any of those aspects, then head off to my website, Nicky Keay Fitness, and see what's going on there.
Okay, amazing. Well, that's super insightful, fantastic, and thank you for your time today, Nicky. And really enjoyed our chat.
Cheers. Thanks.
Thanks.